evening and staying dry from all of the rain that's been kind of coming in and out of Cincinnati today, if you are here in Cincinnati. I'm here to talk about sleep and how it is a necessity, not a luxury. Our journey here today is that we will talk about just a general overview of sleep and talk about sleep symptoms that we would see in adults and how we would treat and manage that in the sleep center. So, to begin, what exactly is sleep? Sleep is this, it's this idea that we are able to rest our bodies and our brains from sort of day-to-day living and what we're doing in our waking hours, right? So, this definition says it's a reversible behavioral state of disengagement from and unresponsiveness to the environment. And it's important for us in order to maintain a sense of balance and a sense of health and well-being, because when we sleep well and we have good sleep quality as well as good sleep quantity, it helps us perform well and feel better. And some of the theories of why we sleep include that the fact that it helps to conserve our energy. So we have about 15% less energy that's expended during sleep compared to when we're awake. It's very important for cognition and memory, especially in terms of, the fact that, if we don't sleep very well, we may have some consequences, which we'll talk about later in terms of decreased intellectual performance, an inability to regulate our emotions, just as some of our examples. And again, it's important for us to consolidate our memories as well. It's also important because when we sleep, there's a lot of regulation of temperature and other body functions. And this is just a slide here over on the left-hand side that indicates that lots of different functions are affected. And body systems are affected when we're sleeping. Our breathing, our circulation, like our heart rate, our blood pressure. So as an example, if we are sleeping and sleeping well, our blood pressure tends to drop by at least 10%, by about 10%, as some of the examples for that as well. We have lots of different things that happen from an endocrine perspective, especially during our non-REM sleep. We might have release of a lot of different hormones, such as growth hormone, as an example. And then it's just really important for us to help to regulate our body and our brain. And it's such an important aspect of it that sleep health is now considered to be one of life's essential 8 from the American Heart Association in terms of optimizing cardiovascular and brain health as well. So why is sleep important for brain health? It's important, I tell people it's important for those frontal lobe functions, our ability to pay attention to things, and this idea of what we call executive functioning, where we, are able to multitask, make decisions, have that working memory. So if we're trying to learn a phone number, for example, we're able to store that information initially before it goes into our long-term memory. And then it is also important for encoding those memories as well. So not just paying attention to things and keeping it temporarily in our brains, but putting it permanently into our memory system so that we can recall that later. And then again, as I mentioned before, the sleep is really important for managing our emotions. The frontal lobe is very key in helping us regulate our emotions. And so if we don't sleep very well, we have a tendency to have increased risk-taking, maybe a little bit more irritable, maybe less patient with the people that we are surrounded by. And so what drives our sleep-wake cycle? I like to tell people that from a practical perspective, there are 2 processes that drive our sleep-wake cycle. So one of them is what we call our homeostatic sleep drive. It's, again, this drive to help us fall asleep. And then there's our internal body clock, or our circadian rhythm, which is driven primarily by this structure called the suprachiasmatic nucleus, or SCN, which is in the hypothalamus of the brain. I tell people that if you have an adequate amount of sleep and good sleep quality, what tends to happen is that your homeostatic sleep drive, which is driven by something called adenosine, it's lowest when you first wake up in the morning. And then it builds up throughout the day and throughout the night until our internal body clock tells us to fall asleep at night. Our internal body clock or circadian rhythm is a little bit over 24 hours in a day. And so there are certain things that entrain it or put it in that 24-hour period. Light is the primary thing that helps to keep it within a 24-hour period. And what happens with light is that light, helps to keep us awake. It's our sort of our signal to stay awake at night or during the day. And then what happens at nighttime is that when there's darkness, there's release of melatonin, which helps us to fall asleep at night as well. So all of these work in concert. These two processes work in concert to tell us when we're awake or when we're asleep. The other thing just to appreciate, and I'm not going to go into full detail on this, is that we have a lot of neurotransmitters and neurochemicals in the brain that drive our sleep-wake systems. And so, again, there's an interplay between all of these neurotransmitters to tell us when we're asleep, when we're awake, and if we are asleep, what stage of sleep we might be in, whether it's that non-REM sleep or REM or rapid eye movement sleep. And REM sleep tends to be our dream state sleep. There's an interplay between all of those. And so the other thing too is that our brains tend to have two switches in our brain, we like to call it. There's one switch that tells us whether or not we are awake or asleep. And there's another switch that tells us whether or not we are in REM or not in REM. And then there are some switch stabilizers, such as orexin or hypocretin, that helps us to stabilize those sleep-wake switches. So, for example, orexin or hypocretin, also known as that as well, tends to stabilize our sleep-wake switch towards turning wake on, and also stabilizing our REM on-off switch towards turning REM off, as an example. And so, again, just to appreciate that there's a very elegant and intricate interplay of these neurochemicals and neurotransmitters in our body. Now, how is sleep organized? We have non-REM sleep and REM sleep. And again, I told you REM stands for rapid eye movement sleep. During non-REM sleep, we have what we call in the sleep world N1, N2, and N3. And so N1 is the lighter stages of sleep, N2 is the intermediate stages of sleep, and N3, which is what used to be called stage 3 and stage 4 sleep, has now been combined and encompasses our slow wave sleep. One thing to appreciate about REM is that our arms and our legs tend to be paralyzed during REM and our dream state sleep as a protective mechanism. But we have that rapid eye movement that tend to occur as well. Each sleep cycle, as we go from the non-REM stages of sleep to REM, lasts about 90 to 110 minutes and tends to be repeated about 4 to 6 times a night. What tends to happen is that throughout the night, we have our greatest percentage of sleep, N3 sleep during the first portion of the sleeping period. And then we have the greatest portion of our REM sleep during the portion right before we're about to wake up. And so just for reference, young adults spend about 50 to 60% of the night in stage N2. REM is approximately 20 to 25% of the night, pretty much throughout the lifespan. And then stage N3 is about 15 to 20% of the night. On the right-hand side here, what you see are schematics of 3 different time points in the life cycle. So on the upper left-hand side, you see a child, and the way that it is on the horizontal axis is the number of hours in bed. On the vertical axis, you see the different stages of wake or the different stages of sleep. And then so one of the things to appreciate is that there are normal changes that occur as a part of the aging process. So for example, children have the greatest percentage of slow wave sleep. And as we get older, what tends to happen is that we have less slow wave sleep, and more nighttime awakenings just as a part of the normal aging process. And so I think that's something to kind of keep in mind, as you know, that there is this sort of normal process that occurs as we get older, as well. So again, the greatest percentage of slow wave sleep occurs in childhood, decreases as we become adults, and then is the least amount when we're older adults as well. So what are the consequences if you don't sleep well? And I think many people can attest to maybe some or more of these things that we see here. You may feel fatigued or sleepy during the day. It may take you longer to respond to things. You may have a more likelihood of having errors. You may not be able to learn as well. Your ability to be flexible in your thinking and pivot, and again, think of the other person in mind, your ability to be empathetic may be challenging as well. There's increased risk-taking, higher emotional dysregulation, and we've found out too, of course, that sleep can decrease resilience as well. And so if you're not sleeping very well, especially if this is going on chronically, then that can cause a lot of consequences in terms of health, as well. So how do we approach sleep symptoms if someone comes to see me? So the way that we tend to look at it is, is someone, sleepy, or are they sleeping too long, or this idea of hypersomnia? Are they having insomnia, so difficulty falling asleep and staying asleep, or may they be having abnormal movements in their sleep at night, such as acting out their dreams, or sleepwalking, or sleep talking? And so these are some of the things that we try to sort out when we see folks. And one thing to appreciate is that there are multiple primary sleep disorders, and a lot of times some people may have one or multiple of them, and part of our job is to try to figure out what people may have. This is just to show you the different categories with the International Classification of Sleep Disorders that people may have. So again, they may have insomnia, sleep-related breathing disorders, hypersomnias of central origin, such as narcolepsy or idiopathic hypersomnia, sleep-related movement disorders, such as restless leg syndrome, circadian rhythm disorders, such as like having a delayed sleep phase or an advanced sleep phase, or in some patients who may have progressive neurological conditions such as Alzheimer's disease, for example, an irregular sleep-wake cycle, and then parasomnia, so these unusual behaviors when you sleep at night. So when we look at sleep issues, we look at it from this five-finger approach. So first of all, is there a primary sleep condition, such as one that I mentioned previously? Are there medical factors? So is there pain, for example, that might be contributing to insomnia? Are there psychiatric or psychosocial factors that might be contributing? Are there medications, or again, this idea of circadian misalignment? I think about medications is that there are a lot of different medications that can contribute and affect sleep. So pain medications, for example, may make people sleepy, or some medications may keep them awake at night. So if someone's taking a stimulant, for example, and they're taking it too late, that can cause insomnia. So those are some of the things that we try to sort out. One other way to kind of think about it is from this whole health model. And so this is from the VA, and this is content that was provided to me by one of my colleagues at the University of Wisconsin, Dr. Vinny Minichiello. But if you look at it, so the way that this whole health model looks at is it's this idea of a circle of health. So in the center, you've got me at the center, the individual at the center. That's followed by mindful awareness, and then understanding our relationship with health. In the green circle, there are various aspects of self-care. So moving the body, our surroundings, personal development, food and drink, recharging, which includes sleep, our relationships with family, friends, and coworkers, the spirit and soul, how we connect, and the power of the mind as well. The dark blue circle is the professional care that people may go to, and then the community also contributes as well. And so our approach to sleep issues, we do have a comprehensive evaluation in terms of someone's sleep history. What time do they go to bed? Well, how long does it take for you to fall asleep? How many times do you wake up in the middle of the night? How long does it take for you to fall back asleep if you wake up in the middle of the night? What time do you wake up for the day? And also, what time do you actually get out of bed for the day? Do you nap? And if you do, for how long? And for us, naps also include dozing. So if you're dozing off in the afternoon or dozing off in the evening, that may contribute to potentially difficulties with sleep when you're trying to sleep. We also ask for other symptoms. For example, if we're concerned for sleep apnea, does someone snore? Does someone stop breathing if they sleep at night? And again, do they have abnormal breathing movements or behaviors in or around the time of sleep? Some other questions to ask, and maybe something for you to reflect for yourself, is what exactly is your relationship with sleep? Is it a positive one? Is it a neutral one? Is it a negative one? And then what does rest or recharging look like for you? And then if we talk about sleep, because some people actually have what we call psychophysiologic insomnia, where, thinking about insomnia or thinking about sleep actually can contribute to difficulty sleeping at night because it can cause anxiety. So what sort of sensations does someone feel? And then what sort of thoughts or emotions arise, even as we're talking about resting and as you're listening to this talk today? We also have a comprehensive sleep history in terms of alcohol, in terms of substance use and lifestyle behaviors, such as caffeine use, alcohol, and drug use. We'll talk a little bit more about some of that later as we talk about insomnia. Again, because of that five-finger approach, we do want to look at the medical and surgical history. Medications are important as well. Changes in weight, we look at, especially if we're looking at someone who has like sleep apnea, for example, which we'll talk about here in just a moment. And then social and life stressors, especially if there's a history of insomnia, because a lot of times these can contribute to difficulty sleeping. And then we have a review of systems, again, looking at, do people snore? Do they have an urge to move the legs at night, which contributes to something like restless legs, for an example? Nocturia, or needing to urinate multiple times throughout the night, may be a sign of something like obstructive sleep apnea. And then pain. A lot of times pain and having chronic pain can contribute to sleep issues as well. Headaches is included in that also. One of the tools that we have to see if someone has a sleep issue is a sleep study. So there are two different types of sleep studies that we have. One is a home sleep apnea test, which only looks at one's breathing parameters. So it looks at airflow, it looks at oxygen levels, it looks at how much effort someone makes when they breathe at night. It's only best to look for sleep apnea, and it may underestimate the presence of sleep disordered breathing. So if it is positive, it helps us to determine whether or not someone needs to be treated. But if it's not, then we need to look at a comprehensive sleep study. So the difference between the home sleep apnea test is that it only looks at breathing parameters versus the comprehensive sleep study, where we have someone spend the night at the sleep center. And there are different sensors that look at brain waves, looks at their eye movements, and looks at the movements of their chin and their legs as well. And those sets of sensors not only tell us whether or not someone is kicking their legs at night, for example, but also it allows us to determine whether or not someone is awake or what stage of sleep that they might be in. We have a whole scoring manual in the sleep world that helps us to determine all of those different things. So the indications for a sleep study are looking for something like obstructive sleep apnea. If someone is acting out their dreams at night, we usually do want to do something like the sleep study to see, first of all, if it's sleep apnea, that might be a contributing factor, which it can be sometimes. Or if sometimes someone has something called REM sleep behavior disorder, where they're acting out their dreams at night and they have increased muscle tone during their dream state sleep. We'll talk a little bit here about restless leg syndrome, but restless leg syndrome is a clinical diagnosis. It's based off of symptoms. It's not based off of what we see on a sleep study. However, a lot of people who have restless legs may have these, what we call periodic limb movements of sleep, where they're kicking their legs at night. On the other hand, some people may have these leg movements that we incidentally find on their sleep study, but they don't have restless legs. So that's just something to keep in mind as well. If someone has insomnia without any other sort of sleep symptoms, then we don't necessarily need to do a sleep study. But if someone has chronic insomnia or sleep disturbance, we may do that just to rule out or to check and make sure that someone if sleep apnea or like leg movements may be a contributing factor. Sometimes we can use the sleep study to rule out seizures, especially if they're having unusual behaviors if they're sleeping at night as well. As we shift over towards some of the sleep symptoms and some of the things and some of the sleep conditions that we see, I did want to make a note in terms of the difference between sleepiness and fatigue. And so when someone is sleepy, what happens is that when they're awake and they're active, they're able to they're able to pay attention and do things. It's when they sit down or given an opportunity to rest where they feel like they need to sleep at night, versus fatigue, where people are just tired all the time, regardless of activity. And a lot of times people can have a mix of the two, but fatigue tends to be more associated with chronic medical issues and conditions as opposed to sleepiness. Although, like I said, a lot of people have an overlap between the two. And sometimes it can be challenging to sort out, what is sleepy and what is fatigue. But it's just something to note that there is a difference between the two. There are many, again, causes of hypersomnia. If you, again, look at the five-finger approach that we kind of talked about as well, medical and psychiatric conditions, medications, not having inadequate sleep hygiene. So if someone is not, or unhealthy sleep habits, if they're not sleeping enough at night, they may be sleeping or excessively sleepy during the day. We will talk primarily here about obstructive sleep apnea, but narcolepsy is also, or idiopathic hypersomnia can also contribute to hypersomnia or daytime sleepiness as well. Just a note on narcolepsy and idiopathic hypersomnia. I tell people it's essentially a 2-week workup. So we, first of all, have to make sure that someone's getting an adequate amount of sleep. So we do either sleep logs or we do something called actigraphy, which is similar to like a wearable device where we track someone's sleep-wake cycle based on movement. But we want to ensure that someone's getting an adequate amount of sleep. In addition to that, we do an overnight sleep study to make sure that they don't have sleep apnea or, primarily that may be causing someone to be sleepy. And then we do a daytime nap test that gives people 4 to 5 nap opportunities to see how long it takes for them to fall asleep and then whether or not they go into their dream state sleep. So we have criteria to determine whether or not someone has narcolepsy or idiopathic hypersomnia. The other thing to note is that people have to be off of medications during that 2 weeks that someone's doing the sleep logs or that actigraphy. They have to be off of medications that may potentially interfere with the interpretation of the tests. So, for example, antidepressants, wake-promoting medications, stimulants, sedating medications, etc. So let's talk about something that is very common and something that we see quite often in the sleep clinic: obstructive sleep apnea. So it's primarily seen, it is seen in about 5% of the population, but can be seen in up to 60% of those over the age of 65. If someone is heavier, they have heart issues or lung issues, they may have a higher incidence of that. It tends to be more common in males, but also can increase as we get older as well. The most common symptom is snoring. And so a lot of times I have people who come in and they say, I snore, but I don't have sleep apnea. Well, we do have to do the sleep study in order to confirm that. But some other symptoms that people may have, they may have insomnia, they may have daytime sleepiness, they may have morning headaches. And the headaches that are associated with sleep apnea tend to be purely with sleep apnea, tend to occur in the morning, and then they can get better after about a half an hour or so. However, we do know that obstructive sleep apnea can be associated with migraines, for example, and other types of headache syndromes. So what happens with obstructive sleep apnea is that, this top picture shows you what happens normally during sleep. You have an open airway. But what happens with obstructive sleep apnea is that you have a blocked airway. And the result of that is that you can have a lot of disruption in your sleep. Your oxygen levels can drop, and your brain might not get into the restful stages of sleep as well. Obstructive sleep apnea is a risk factor for high blood pressure. Also has an increased risk for strokes and heart disease. It can also contribute to issues with memory and thinking. And then you're at a higher risk because if you're sleepy, you're at a higher risk for car crashes as well. There's been some data that also has shown that obstructive sleep apnea may contribute to the changes that may be associated with conditions such as Alzheimer's disease, for example. Some other consequences, it may be, it has been associated with mood issues, such as depression, difficulty tolerating or monitoring one's blood sugars, decreased quality of life, increased health costs, and in males, erectile dysfunction as well. And one other thing to kind of keep in mind as we're talking about the importance of sleep health that I wanted to mention was that another function of sleep is that it's this idea that sleep helps to sweep out toxins in the brain. And so when someone has disrupted sleep, such as sleep apnea, that's maybe one of the reasons and one of the mechanisms why it may be associated with things such as Alzheimer's disease. So again, we evaluate for sleep apnea by using a sleep study, either the home sleep apnea test or the comprehensive sleep study. And a lot of times that may also be dictated by what the insurance will allow us to do. So a lot of times we do have to start out with the home sleep apnea test first. The primary treatment for obstructive sleep apnea is what we call CPAP, or continuous positive airway pressure. So what CPAP is, it's a mask, and there are different types of masks that we have, but it's a mask that's hooked up to a device that pushes in room air and opens up the airway spaces in the back. And that, so the thought process is that if someone has obstructive sleep apnea, using something like this positive airway pressure device can help to keep the airways open. And there are ways that we can monitor that and troubleshoot that if people are having challenges with it. Now, some people may have challenges with using CPAP. And so some other things that we can consider, one of the things that we sometimes do is we switch someone from a CPAP to what we call a bilevel PAP. So CPAP, it's the same pressure setting when you're breathing in and the same pressure setting when you're breathing out. But a bilevel PAP, it's a higher pressure setting when you're breathing in and a lower pressure setting when you're breathing out. And sometimes if people are feeling claustrophobic or if they're feeling like they're pushing against the device when they're trying to exhale, sometimes a bilevel PAP can be helpful for that. There are some other alternative treatments that we can consider kind of depending on the severity of one's sleep apnea or the degree of one's sleep apnea. So someone may have the cutoff for sleep apnea is having what we call an apnea-hypopnea index of at least 5 events per hour. Mild sleep apnea is 5 to 15 events per hour, moderate is 15 to 30 events per hour, and greater than 30 events per hour is considered to be severe sleep apnea. If someone is not able to tolerate CPAP or the bilevel PAP for whatever reason, sometimes people may be a candidate for some of these alternative treatments. The oral appliance is a device. It's in the an example of that and is in the middle here, where a dentist makes impressions of the teeth and they make a device that pushes the lower jaw forward to open up the airway spaces in the back. It is best for mild to moderate obstructive sleep apnea. People usually have to have their teeth because the mouthpiece needs to be able to grip onto something. And then one of the other things that we always ask for is whether or not someone has jaw pain or jaw pain, because if someone, the way that this device works is that it does put stress on that jaw joint and then may contribute to jaw pain. And one of the other side effects is that it may, over time, change someone's bite. Surgical options, one of the things that I get asked about a lot is the hypoglossal nerve stimulation. And so this is the picture on the left. Kind of gives you a schematic of what that looks like. The brand name for that is Inspire. The way that this works is that it is a device that's implanted in the chest that stimulates the nerve to the tongue and protrudes the tongue forward. And so it is potentially indicated, it is approved for people who have moderate to severe sleep apnea who have a body mass index of under 40 kilograms per meter squared, or Medicare criteria under 35 kilograms per meter squared, as an example. And the other thing too is that it is, you have to use a remote in order to activate it and pause it and turn it on and turn it off. So the ability to do that is important as well. One of its main side effects is insomnia. So If someone is having difficulty falling asleep and staying asleep at night, this may not be the best option for those people, because sometimes people feel the tongue protruding forward. And if you're a light sleeper, that may make it more challenging to fall asleep at night. The other thing, too, is that there is a process to determine whether or not someone is even a candidate for Inspire. So these are usually implanted by ear, nose, and throat doctors. And you have to go through general anesthesia at least twice. So the first time is to do what we call a sleep endoscopy to see whether or not someone's airway is even a candidate for the device. And then the second time, of course, is to implant the device itself. Positional therapy. So if someone has difficulty, has more sleep apnea when they're sleeping on their back compared to when they're sleeping on their side, we can consider something like positional therapy. An example of this is the Zoma device, which is FDA cleared, not covered by insurance, but is on the right here. And so there are ways that we can do that. The old school way of doing it is wearing what we call the tennis ball and a t-shirt technique, wearing a t-shirt, putting pockets in the back, putting tennis balls in those pockets, which then makes it less comfortable for people to sleep and has them roll over to their sides a little bit more as well. One of the newer treatments is tirzepatide, which is one of the weight loss medications. Zepbound is the brand name for it. It has been FDA approved for moderate to severe sleep apnea in those who meet the criteria for obesity. It is not a substitute for CPAP or any of these alternative treatment. The way that it works is that it helps through weight loss. And so sometimes if people lose weight, a lot of insurances allow us to repeat another sleep study if someone's lost at least 10% of their body mass index or their weight from their initial diagnostic study, then that weight loss can certainly help and sometimes even resolve sleep apnea, but not always. So that's obstructive sleep apnea. I will put a side note in terms of central sleep apnea, because some people may know of someone who has that. The difference between obstructive sleep apnea and central sleep apnea is that obstructive sleep apnea, again, is that there is an obstruction of the airway that causes someone to stop breathing at night when they're sleeping, versus central sleep apnea. So what happens is that people stop breathing when they sleep at night. And unlike obstructive sleep apnea, where if there's a blockage, the chest and the abdomen try to compensate for that. We see effort in there as a compensation to try and overcome that blockage. People with a central sleep apnea don't have that movement in their chest and their belly. So that's how we kind of make the difference between the two. A lot of times that can be due to heart issues, sometimes neurological issues. Medications such as pain medications such as opioids can contribute to something like sleep apnea or central sleep apnea as well. So switching over to something else that's common that we see is insomnia. And we see insomnia a lot in our clinic. And there are lots of different things that cause insomnia. It's associated with difficulty falling asleep, maintaining sleep, or having non-restorative sleep that leads to difficulties with their fatigue, with function during the day, usually for about at least 4 weeks. Some people think that insomnia is just difficulty falling asleep, but we also contribute difficulty staying asleep as part of that as well. Again, the 5-finger approach, there are lots of different things that can cause insomnia. Pain, asthma can tend to be worse when we're sleeping at night. If someone is having dementia or has dementia, that irregular sleep-wake cycle can contribute. Depression and anxiety may contribute to early morning awakenings as well. Medications can contribute, lots of different medications can contribute to insomnia. Unhealthy sleep habits, which we'll talk about here. And again, these primary sleep disorders can contribute, and then environmental factors as well. Going back to that whole health model that we kind of talked about, looking at some other environmental factors, there's been some studies that have shown that loneliness can lead to reported sleep disturbance, not necessarily sleep duration, but sleep disturbance in general. And then if someone has a history of emotional trauma, especially during childhood or even with intimate partner violence, that can contribute to insomnia as well. And so we look at it from what we call a 3P model. What are some of the predisposing, precipitating, and perpetuating factors? So the predisposing factors are, is someone does someone just is more prone to being a light sleeper or having a propensity of what we call hyperarousal? So people who have anxiety, as an example for that, or mood disorders, or there may be a family history of insomnia or sleep difficulties. What are some precipitating factors? So a lot of times what we see is that there is a precipitating factor or a stressful situation that kicks into insomnia. So a diagnosis that may be catastrophic, or even a stressful situation at home or at work that triggers someone to have insomnia. And then medications or medical conditions can contribute as well. And then in terms of perpetuating factors, and especially in chronic insomnia, where people have been having insomnia for at least 3 months, the unhealthy sleep habits really can contribute as well. Excessive caffeine use of alcohol before bedtime, or using alcohol to try to go to sleep at night, which is not a healthy way to go to sleep at night, because alcohol helps people fall asleep, but then it wears off in the middle of the night and then can contribute to sleep disturbance. Not only that, but also can contribute to sleep apnea as well. And then lying in bed for excessive periods of amount of time. Ideally, you want your bed for sleep only. And the time that you're in bed is when you should be sleeping as well. So people are in bed for an excessive periods of time. People are training their brain that their bed is for something other than sleep, which actually can feed into insomnia as well. I will just make a note that there are different treatments that are out there for insomnia. I'm not going to go in full detail on that, but just to know that there are many medications that are out there that are used for insomnia. The one thing to think about for this is that it's ideally used for acute insomnia. So less than 3 months or so. In an ideal world. Although if someone has chronic medical conditions, things like that, sometimes chronic use may be beneficial. Some of the things that can be considered are like antidepressants with sedating side effects. Anti-epileptics, I say that with caution, but if someone has restless legs, for example, gabapentin may be used to help with that. But we know that the studies have shown that behavioral treatments result in more sustained benefits over time. And the other thing, too, is that a lot of the medications that we use for insomnia may actually contribute to issues with memory and thinking. My colleagues in the Memory Center, the Brain Health Center at UC Health, have a card that kind of tells you some of the things that are not necessarily good for brain health. And a lot of the medications for sleep are included in those. So one of the things that I learned during my Osher faculty fellowship is this sort of noise reduction approach to insomnia, which I found really intriguing. And so would love to share with us today. This incorporates some of the behavioral strategies that have been shown and proven to help with insomnia. But this noise reduction approach is looking at what are some ways to reduce the noise of our mind, reduce the noise of our body, and the bed noise that may contribute to insomnia as well. In terms of reducing body noise, this is where making sure that the treatments of other medical conditions and things like that are optimized as much as possible. And that includes other sleep disorders, managing the sleep side effects of medication. So for example, I see a lot of patients who have Alzheimer's disease, for example, and so they may be started on donepezil or Aricept. And so the way that works is that it increases the amount of acetylcholine, which is important for memory and thinking. It's also important for memory. But the other thing, too, is that acetylcholine is also a critical neurotransmitter for wakefulness. And so even though the recommendations, I think when you get the insert, it's take it at bedtime. My colleagues in the cognitive clinic tend to tell people to actually take it in the morning because something like donepezil can contribute to insomnia and nightmares even, and difficulty with sleeping. Avoiding nicotine use and then caffeine use we'll talk about here in just a second. Nicotine is activating. It actually keeps your brain active and makes it more challenging to sleep at night. Reducing the mind noise. And this is where some of the behavioral techniques that have been studied, is where we focus on here. I have an asterisk behind behavioral therapy for insomnia because that really is the gold standard way of treating insomnia. Sleep hygiene is, and we'll talk about healthy sleep habits here. It is a necessary but not sufficient way of treating insomnia. We have to look at all of the different factors in treating, underlying sleep conditions, medical conditions, and things like that as well. But what we do with cognitive behavioral therapy is that, it's not only looking at the behaviors that may interfere with sleep, but also trying to reframe one's relationship with sleep as well. So the tenets of cognitive behavioral therapy include that cognitive restructuring or reframing, stimulus control. So that again is keeping the bedroom for sleep only. And we'll talk a little bit here about that. But if you're lying in bed for more than 20 minutes and you're not sleeping, you're actually contributing to difficulty sleeping at night. So it's one of the reasons and one of the rationales behind telling us, telling people to actually try to get up out of bed if you can and go into another room and do something that's boring and not engaging. Sleep restriction, again, goes into this idea of trying to maintain your time in bed for sleep only. There is a process sometimes, where we actually restrict people's time and then gradually increases it to kind of where their desired sleep duration might be. Relaxation practices we'll talk about here. Progressive muscle relaxation is important. And then in this integrative medicine book, they were talking about like restoring dream health and having like, a positive relationship with dreams can be helpful too. So let's focus on those healthy sleep habits and the sleep hygiene here in just for the next few minutes. We talked about the homeostatic sleep drive earlier in our talk today. And what we told you was that, or if you may recall, we said that if you have adequate sleep duration and adequate sleep quantity the night before, our homeostatic sleep drive is lowest when we first wake up in the morning and builds up over time until we actually, our internal body clock tells us to fall asleep at night. The two things that weaken that homeostatic sleep drive or that signal to go to sleep at night are number one, caffeine, and number two, taking prolonged naps during the day or evening or dozing off too long. And so caffeine is what we call, remember I said the homeostatic sleep drive is driven by adenosine. Caffeine directly weakens and decreases the amount of adenosine in our system. And it is in our system 3 to 5 hours. Half of the caffeine in a beverage is still in our system about 3 to 5 hours after we last consume it. So we tend to recommend no caffeine after 2 o'clock in the afternoon, and that includes decaffeinated beverages. So there are fully caffeinated beverages, decaffeinated beverages that have less caffeine, and what you want are caffeine-free beverages after 2 o'clock in the afternoon. In terms of dozing off and prolonged naps, if you have to, we try to tell people to try and limit it to no more than 30 minutes, if at all possible. So again, the brain and the body like consistency. So try to keep a consistent sleep schedule. That's in alignment with the internal body clock. Managing alcohol and caffeine use, eliminating caffeine after 2, and minimizing naps as much as possible. These are a couple of resources. The VA has a free insomnia coach app that kind of provides people with some cognitive behavioral approaches. The one that I tend to recommend, it's more of a book. It's called Say Goodnight to Insomnia. It's written by a psychologist by the name of Greg Jacob. It's an older book, but has been helpful for some of the folks that I've seen in the clinic. And then in terms of progressive muscle relaxation techniques, the University of Wisconsin has a nice handout that you can look for that. Other considerations in terms of mind noise, I'm just saying here that relaxation therapy, does have some benefits, especially and can have other benefits, including pain reduction and stress management. Biofeedback, where someone is with someone who is trained, can kind of look at their heart rate, for example, and find ways to kind of slow down their heart rate. For that as well, may be helpful. Mindfulness can improve insomnia severity. And the fact that there was no difference between that and people who were controls on the sleep studies does favor mindfulness over doing nothing at all. But the time investment may be a challenge. But we have a great mindfulness series, and so sometimes with our Osher Center here, and sometimes that can be helpful as well. In terms of reducing the bed noise, have your bed and your bedroom be creating that sense of sanctuary, keeping the bedroom stress-free and work-free, and not. We also don't want you to be thinking in bed as well. So trying to be, trying to limit stressful imagery exposure, not looking at your clocks, and trying to maintain peace with your sleep partner can be helpful as well. Again, talking about stimulus control, keeping the bedroom for sleep only, going to bed only when you're sleeping. And if you can't fall asleep or stay asleep within 15 to 20 minutes, try to go into another room and do something that's boring. And then if you want to try to anchor your sleep schedule, keep a fixed morning rise time. That is the thing that kind of helps to, anchor a sleep schedule as well, and avoiding naps, as we talked about. Exercise can positively influence insomnia. It can increase the deeper stages of sleep as well. I think one of the things, a shout out to Dr. Barbara Walker and our nature medicine program here at the Osher Center, you not only get some physical activity, but there's been some studies that have shown that being exposed to nature can also help with sleep as well. From food and drink, from that whole health perspective, some other things to kind of consider. We talked about how melatonin can help people fall asleep at night. These are just a list of some of the food sources that may have melatonin in it. So there's some nuts and seeds, such as walnuts and flax seeds, vegetables and fruits, such as asparagus, tart cherries, grains, such as rolled oats, barley, and rice, and then animal-sourced foods, such as eggs and fish. Then tryptophan, which is an amino acid that helps to create some of those neurochemicals and neurotransmitters that are associated with sleep. Some of these, most people know about turkey, but there's some other ones here that people can consider as well. If someone has a history of reflux or heartburn, trying to avoid those reflux triggering foods such as chocolate, tomatoes, onions, for example. And the other thing too is meal timing. So the liver is really strongly driven by our internal body clocks. And so trying to stop within 3 hours of bedtime can be helpful in optimizing sleep as well. As we conclude here in the last few minutes, I'm just going to want to briefly talk about other sleep conditions that we may see. One of them is restless leg syndrome. Again, it is a clinical diagnosis that's based off of symptoms. And someone has to have all four of these meet all four of these criteria in order to make the diagnosis for restless legs. It's an urge to move the legs. It's at night. It's worse at rest, and it's better with movement. And then the other thing too is that it has to be associated with functional challenges, especially during the day, or difficulty sleeping at night. The non-medication approaches to this, a lot of times we check iron status because lower iron levels, specifically a lower ferritin level, may contribute to restless legs. You want to try and recommend mentally alerting activities before bedtime, and then weaning and abstaining from caffeine, because another thing that caffeine can contribute to is restless legs. Medications, so antidepressants, for example, or even antihistamines. So, over-the-counter antihistamines, allergy medications can exacerbate or worsen restless legs. And then moderate but not intense exercise can be helpful too. There are some medications that we can try. I think I mentioned here gabapentin as it's an alpha-2 delta calcium channel ligand. In the way past, it used to be used as a seizure medication, but there are much better seizure medications now on the market, and so that are used. But the gabapentin or pregabalin can be helpful. The dopamine agonists, such as ropinirole or pramipexole, have now actually been downgraded by the American Academy of Neurology as a treatment for restless legs because of long-term side effects. So it can cause impulse control issues where people have overspending, or, as an example, there's been case reports of people gambling tens of thousands of dollars away being on these medications, or what we call augmentation. So they have earlier symptoms of the day or spread of the restlessness to other parts of the body. And then in refractory cases and people who are really struggling, sometimes low dose opioids can be helpful as well. And so some other sleep conditions that we see, we kind of briefly talked about the REM sleep behavior disorder, parasomnias, sleepwalking in adults, or these non-REM parasomnias or sleepwalking, for example, in adults tends to be due to medications. So sleeping medications such as zolpidem is a common culprit for that. In children, it's because these non-REM parasomnias are more likely to occur during that deeper stage of N3 sleep. And again, we have our greatest percentage of N3 sleep in childhood. That's one of the reasons why you may see like the sleepwalking, sleep talking, things like that more commonly in children, but they grow out of it. And then we talked a little bit about some of the circadian rhythm disorders on the right-hand side here as well. So I'll conclude here by talking about some tips to improve sleep. Having a consistent sleep schedule, a regular sleep time and bedtime. One thing to note, the National Sleep Foundation recommends 7 to 9 hours of sleep at night for adults between the ages of 18 to 65. It's 7 to 8 hours of sleep for those over the age of 65. Optimizing your medical and psychiatric conditions, reviewing the medication list, looking at the primary sleep conditions, trying to minimize naps, no caffeine after 2, avoiding nicotine and alcohol, and keeping the bedroom for sleep only, and keeping that bedroom for providing that sense of sanctuary, having a cool environment as well. So with that, I say good night and sleep clean, and I will stop sharing and see if there are any questions.
Thank you so much. That was great. We do have a couple of questions. It looks like we have 4 right now, so we'll see how many we can get through. The first person asked that they said they're 62, well beyond menopause, and they don't have hot flashes during the day, but they do have them, and they wake up 2 to 3 times per night. So it's causing a big disruption. Do you have any suggestions on how to handle these? And they say that MG causes reflux, but their bed is elevated and they tried T's and it's not working.
Yes. Oh, so in terms of like hot flashes in particular, well, I think the first thing is, certainly, speak with the GYN and see if they have some suggestions. There have been some reports that gabapentin may be helpful for hot flashes, but again, that's usually prescribed by the gynecologist or the patient's primary care physician or women's health specialist. Some other things that people have tried, they have like a fan in the room, or they have something like a cooling blanket or something like that in the bed that can be helpful.
Thank you. Okay, so another person asked if someone takes melatonin pills, is there a dose such as 5 milligrams, 20 milligrams, something like that may work best?
So melatonin helps with sleep onset. It does not help with sleep maintenance. We do tell people that lower is better. So in the literature, lower is like ideally 1 milligram or less. If it's specifically for insomnia. Although I know that the formulations are like, 1, 3, 5, 10. But lower is the better, is just the general rule of thumb. I think the other thing too is that, there was one study that looked at like all the different types of melatonins, and there's variability in actually how much melatonin is in a supplement. So, one of Consumer Reports, for example, like they made the recommendation that if you're looking for a supplement, you want to look for something like, the USP label or the US, I think it's don't quote me on it, I think it's Pharmacopedia or something like that, that shows that there's been at least some sort of quality control to look at that.
Okay. And then the next question is, if someone does nap, how much is enough versus too much?
30 minutes or less, ideally.
Perfect. Okay. Someone says time as a patient in hospital can be very disturbing to sleep due to checking vitals, drawing blood, weight check. Anything the care team can do to help a patient transition to home without a sleeping challenge? without it being another pill?
Yeah, that's a really good question. There's actually there's some literature that's looking at this. I think in the ICU in particular, I think, well, actually just in hospitals in general, there's been some literature like, can you give a period of time where, at night where it's respite time for the patient who's in the hospital. So, yeah, so I think there are some more systemic issues, organizational issues that can help with that. But I think also, as an advocate for as a patient or even as a family member, as a patient advocate, you may even talk to the care team and say, hey, what can we do to maybe minimize the amount of time that needs to be, that people come in and out, so that my loved one or I get the rest that I need or they need.
All right, the next question is sometimes I sleep 6 hours and I feel great the next day, and sometimes it's not enough. Do you know if there's a reason behind this?
I think it would depend. What I would recommend is maybe track, some of the things like I've had some people who've tracked their sleep and they found, oh, well, if I eat sugar too late or if I, drink alcohol, I don't sleep quite as well. So one of the things that I would recommend is maybe just kind of tracking and not too intensely, but just kind of saying, oh, what did I do here? What are some of the patterns that I can see? And maybe you'll be able to figure out what some of the triggers for more difficulty sleeping might be for you.
All right, someone asked, I was diagnosed with apnea and used to get up 1 or 2 times a night. Now they're using an oral appliance and sleep through the night, and an app to record snoring shows it has been reduced by about half, unless they're completely exhausted. Do you have thoughts regarding the adequacy of the appliance?
So what I usually tell people is that there's usually a process, that a gradual adjustment of the oral appliance that a dentist makes. And so what we typically do is that once the oral appliance has been completely adjusted, then we repeat the sleep study to see if the sleep apnea has improved.
Okay. Is magnesium glycinate useful to help with insomnia?
Some people have found that it has been useful.
And then we have two more quickly if you have time. One person
Sure.
says they're a school counselor that works with high school students. They have a student that speaks, they have students that speak to them about poor and interrupted sleep. Do you have suggestions for adolescents specifically?
Well, I think if there's, the Cincinnati Children's Hospital has an excellent sleep program. And so I even tell parents who can't sleep well because their children don't sleep well that, maybe getting an evaluation there, talking to the pediatrician and getting an evaluation there for a comprehensive evaluation can be helpful.
Okay. And then finally, is there a connection between sleep apnea and having to urinate frequently during the night?
Yes. So the way that we think about this, again, I think I mentioned that our blood pressure tends to drop by at least 10% if we're sleeping well. And so those are what we call dippers. People who have obstructive sleep apnea tend to be non-dippers. And then as a way to kind of compensate for all of that, the way to compensate for that is to actually urinate at night. So that can be a contributing factor. I think one of my colleagues who's a urologist says if someone is just having pure nocturia and no other sort of symptoms that they can find from a neurological perspective, they encourage them to get a sleep study. And as a matter of fact, we do have people who have less nighttime awakenings due to the need to urinate after they've been treated for that.
Okay, thank you. All right, well, I think that's all the time we have tonight. I appreciate you so much, Dr. Milano, and thank you everyone else for being here tonight. Everyone will receive an email with this recording as well as other resources from us, and we hope you will stay engaged with us and hopefully join us at an upcoming class or event. So thank you.
Thank you.
Bye.
Have a good night.